refinement in the Juvenile Rehabilitation Administration by ethnicity. And you see the disproportionality compared to state and local populations of African Americans or youth of color generally, compared to the representation in the state juvenile correction system. And then you see even more disproportionality in those who are referred from our local King County. And these rates of disproportionality rival those you find in traditional areas where you think disproportionality might be in play, like I work in Louisiana or Arizona, and our disproportionality is every bit as eye-popping, mind-boggling, distressing in Washington State. And I was looking at this slide to update it because these data were from 1996. If I look at the 2005 data, then they were exactly the same. We're incarcerating less kids, but the proportionality hasn't changed. And so when that disproportionality occurs, whether it's in juvenile delinquency and incarceration or in other areas of health and well-being, there should be a drive to develop interventions that address directly that disproportionality, understanding the cultural factors both in the expression of the disorder and the response of the systems to the disorder. And so that drives us to looking for these evidence-based practices. And then this is just an example of the, I call it the demographic reality of the world we work in. I work with Dr. Troopin in a clinic in Seattle called the Primetime Project, where we were focused on working on the disproportionality problem with African Americans in King County. So he developed, and I worked in a program that served primarily African American clients. But if you look at even what this culturally specific program, who this culturally specific program served, you can see the range of ethnic, gender, sexual identity, and sexual orientation backgrounds of our clientele, putting a great deal of pressure on our workforce, the supervisors, the clinicians, to find ways to be culturally competent. And for most of this, you're not going to be able to pull off the shelf the evidence-based manual for working with transgender, Peruvian, biracial adolescents. You have to find ways to adapt in the microclinical sense. And then you have to find ways to adapt in the programmatic sense in order to provide these practices effectively. And so some of the principles that would drive whether or not we think an empirically supported treatment or an evidence-based practice is a fit for diverse clientele would be first to look for, is that manual available that I just wished for? Is there a language or a culturally specific variant of a practice available? And that's very rare, actually, that you will find the treatment program for this demographic group for this specific problem area. And so the second question, the level that I recommend going to is, does this evidence-based practice, or I'm using empirically supported treatment here, have external or ecological validity? That is, do we think that the ways and the mechanisms in which this intervention works are generalizable and are adaptable to the environments in which they're being delivered in? And that's one of the big tests of a high-level evidence-based practice, is if it's been successfully transported outside of the university laboratory of the developers and have people implemented this in the real world. A third level of analysis is simply in these trials that determine the evidence base of this practice, was there a representative sample? Has anyone done this, and has anyone tested this with even just a proportionate sample of the group we're interested in? And that's not always the case. And then sometimes our evidence-based practices are diagnostically specific, and we know that there are variants cross-culturally in the expression and the experience of mental health conditions. And so there's a fair question to ask is, does the practice address or able to address those? And I think an important step in determining how well an evidence-based practice is going to fit is, does does the practice itself or does the provider that's delivering the practice include orientation and engagement strategies within the intervention? The delivery of a intervention that's working on solving the problem in the absence of strategies for engagement that we can hold the providers accountable to will be insufficient for us. We really want there to be ways that the treatment is delivered that we can then adapt culturally. So let me talk a little bit about some of the, what I call these adapters. So what do we need to know in order to appropriately refer to evidence-based practices? Well, one is we need to know something about the cultural competence of those who are delivering the intervention. And a very, very simple continuum of addressing diversity is that we can look for, at the very minimum, cultural sensitivity. That is, do we have providers who are aware of and respond to the differential impact of their service on the clients that they're serving? Do they recognize that, for example, you may need to have differential hours of operation, you may need to attend to transportation and childcare issues, you may need to have a sliding scale, those kinds of things that are simply the very bare bones of cultural competence, which is being sensitive that your intervention may not be equally received by all groups in all places. And so while that seems incredibly simple, the fact is we don't always have providers that rise even to that level. Instead, they're sort of prepared to sort of passively deliver an intervention to those who come to them instead of attending to who's not coming to us that needs these services. I'll talk some more about cultural competence, which is the meatier, the sort of clinical practices that you can look for. And then cultural specificity is the one that's really nice when you find it, but much rarer and much less likely to be specified for both your client's ethnicity and the conditions with which you want to treat. So you just don't have a huge repertoire of choices there. So we tend to focus on the middle here, which is cultural competence. And so one of the things that we can do is look at culturally competent practices. Are there things that are happening in the clinical intervention in addition to adherent delivery of the practice? And some of these are very straightforward culturally competent practices. That is, does the provider know how to present interventions in ways that are engaging, including the way they use language, the way they use diagnostic labels, the way they refer to intervention. So for example, calling your parenting intervention parent training, right? It's not only not culturally competent, it's not probably generally competent. Instead of using language that allows parents to be empowered, ensures them that you're drawing on their expertise, and that in fact what you are is a supporter of parenting, not a trainer of parenting. So that kind of language use will be important. And these are in some ways relatively easy feedback to give to agencies that you're working with, and providers that you're working with, and their training and changes in their practices that they could achieve. Another one is this at this sort of cultural sensitive level also, is just acknowledging and using similarities and differences between individuals to shape and enhance the relationship. That is, the culture becomes a central aspect of how the providers are operating. That they're talking about culture, they're talking about the strengths of culture, and they're giving clients the opportunity to be who they are rather than sort of having the client be forced to assimilate to the conditions of the treatment.